Welcome, everyone, to the Institute of Medicine of Chicago. My name is Maurice. I'm a fellow of the IOMC, co-chair of the program committee. On behalf of the IOMC, I want to thank you for attending today's webinar. Today's session is entitled Resistance to Childhood Vaccines. Is this a rising public health issue? We are fortunate to have three outstanding speakers with us today that will share their insight and expertise. During the pandemic, one of the most concerning issues and challenges that has arisen has been resistance to vaccines. In fact, public health has been at times under siege, and we have had to work mightily to inform the public to get the vaccines that are part of the recommended series for COVID. So how do we as public health, as healthcare leaders, help to address these issues, communicate the implications, and talk about public trust? It would be one thing if this were just had to do with COVID vaccines, but one of the very important issues that we've learned is that resistance to all vaccines has been on the rise. We've seen this highlighted in many articles in popular press, in addition to the scientific studies that many of us have access to. So our session today will help us look at how we can better address this and understand the background. Our presentation will be followed by a question and answer period, which will help to address some of the questions that you have. Please look at the Q&A function in your Zoom app and write down any questions you have during the presentation. There, we'll come back and remind you of that. The learning objectives today are, number one, to identify the potential issues of resistance with childhood vaccinations, discover the immunization landscape in the US and specifically in Illinois, and obtain latest updates and implications on vaccinations. So we have three speakers that are very well versed in this area. Now, welcome our speakers today. First off will be Dr. Jacqueline Korpix, who is a medical director with the Cook County Department of Public Health and a COVID-19 lead there, as well as a pediatrician with Cook County Health. She's also associate program director at the Cook County Health and Northwestern Feinberg School of Medicine, General Preventive Medicine Training Program, and assistant professor at Northwestern Feinberg. She is joined by Stephanie Atella, who is the Chief Program Officer for the Illinois chapter of the American Academy of Pediatrics. And our third expert today is Dr. Susan Sirota, who is chair of the board of Pediatrust, the largest network of pediatricians in Illinois. She's also a clinical assistant professor of pediatrics at Northwestern Feinberg School of Medicine. There's much more information about these speakers on the IOMC website, and I encourage you to look at that. So a couple of housekeeping issues before we get started. If you're visiting with us for the first time, the Institute of Medicine Chicago is an independent nonprofit organization of leaders in the health field, interdisciplinary leaders who collaborate to improve the health of the public. Drawing upon the expertise of a diverse membership and other leaders, we address critical health issues through a range of programs and other activities, such as the monthly seminars that today is an example of. So in that vein, I want to share with you that our next program on April 20th will be a live program at the Safe Haven Foundation from 8 to 10 a.m. Central Time, addressing the importance of rebuilding the lives of the homeless and the challenges, including substance abuse and other behavioral health issues that are often barriers to care. So I really encourage those who have time to come out to Safe Haven. There's more information on our website about that. And finally, just to mention that we do have a series of awards that we give out in June of this year, and the general community is welcome to participate in that. So again, I want to encourage you to look at the IOMC website and submit a nomination for the 2023 Healthcare Awards that will be held Thursday, June 22nd at Venue 6, again, a live program. So with that, let me introduce Dr. Korpix. We look forward for hearing from you today and all about the issues that are very concerning to us all.
Thank you, Dr. Lemon, for the introduction, and thank you all for being here today. Next slide, please. Children are a large part of our population, 22% based on 2021 census data. As you know, children start their vaccinations right at birth. So you can see 0.5% of the population, or 1.8 million, are under 6 months, 5% or 17 million are 6 months to 4 years, and about 9% or 28 million are 5 to 11, and 8% or 26 million are 12 to 17. Next slide, please. The WHO and UNICEF estimates of national immunization coverage provide the world's largest data set on immunization trends for vaccinations against 13 diseases given through regular health systems. For 2020, this data was provided from 160 countries. We saw that globally, the vaccination rates dropped for all of the basic childhood vaccines, leading to an estimated 23 million children missing out on important vaccines like diphtheria, tetanus, and pertussis, and measles. Next slide. To control vaccine preventable diseases, we think a certain percentage of the population being covered is required. So for example, we think we need at least 95% uptake of the 2 vaccine doses for measles to protect the overall population, especially to protect those who are too young or too immunocompromised to receive certain vaccines. The COVID-19 pandemic disrupted routine immunizations as people were fearful or unable to get to their usual appointments, or offices were closed. And this led to millions missing out on important vaccines and thereby leaving populations unprotected. In addition, many mass vaccination campaigns all over the world were postponed during the pandemic, affecting millions more people. And concerns are not just for outbreak-prone diseases. At already low rates, vaccinations like the HPV vaccine, which protects against cervical and other cancers, also significantly decreased during the pandemic. Next slide. In the US, coverage for vaccines decreased each year during the pandemic in the majority of states. The exemption rate did remain low at about 2%, but there was an increased percentage of those without any formal exemption that were not up to date. So as we return to in-person learning, schools were not tracking and enforcing these immunizations like they had been pre-pandemic. And schools also experienced a decrease in overall enrollment. And as you may already know, state and local school vaccination requirements are one of the main, if not the main way, we protect students against vaccine preventable diseases by making sure kids are up to date. And so I've come to realize that schools themselves and their leadership don't always recognize this role that they play in public health. Next slide. In addition to disruptions in school vaccine enforcement caused by the pandemic, there's been an increase in childhood vaccine hesitancy and a corresponding use of non-medical exemptions to abstain from vaccination. That's also negatively impacted public health. So this has many in the field calling for an elimination of non-medical school entry exemptions, as has been done in about 6 states to date. In Illinois, we do allow medical and religious exemptions, but you do have to meet with a healthcare provider for either type of exemption. For religious reasons, by law, parents or guardians who object must submit a certificate of religious exemption signed by a healthcare provider to the school. Next slide. This slide shows our coverage specifically for the MMR vaccine compared to other states. So state immunization programs are eye care conduct annual kindergarten vaccination assessments to monitor school entry, vaccination coverage with all state required vaccines. For the 2020-2021 school year, coverage was approximately 94% for all required vaccines, which is about 1 percentage point lower than the previous year. And then during the 2021-2022 school year, coverage decreased again to just 93% for all state required vaccines. Of note, the exemption rate remained low both years at about 2%. So there was a marked increase in those without an exemption that were not up to date with MMR vaccine. So you could see that Illinois, as well as most other states, have not been reaching the target coverage of 95%. You can see we're at around 91 to 92% coverage for MMR, the DTaP vaccine, polio, and varicella, so slightly below the national estimate. Next slide. Implications of low childhood vaccination rates include the potential to again overwhelm the public health and healthcare system with outbreaks outside of just COVID-19. And burnt out healthcare providers have been reporting having an especially hard time emotionally and mentally caring for patients who they know their hospitalizations could have been prevented by a vaccine. Next slide. A measles outbreak in central Ohio that just began this November sickened 85 children. None of them died, but 36 were hospitalized. There were reportedly small pockets of communities where families decided not to get their children vaccinated as they were influenced by false information that was distributed about the MMR vaccine causing autism. You may have seen that there's also an outbreak in Kentucky. Measles is extremely contagious, much more contagious than at least the initial strains of COVID. So contagious that if one person has it, up to 90% of people close to that person who are not immune will also become infected. But just 2 doses of the MMR vaccine are about 97% effective at preventing measles. Next slide. Here are the influenza ICU admissions in Illinois from 2021 to 2023. As you all know, we were hit early and hard by the flu this year, and flu cases peaked much earlier than in prior years. While it's a bit harder to track influenza vaccine coverage as it isn't required, nationally, we know that flu vaccination coverage also decreased during the 20 to 21 and 21 to 22 seasons for both children and adults. Next slide. During October of 2022, we struggled with only 6% of PICU beds available across the state of Illinois. Of course, many of these hospitalizations were due to RSV, which we do not yet have an approved vaccine for, but many were due to influenza and COVID, which could have been prevented by vaccination. Next slide. So while children generally do better with COVID-19, we do have to get the message out that they can and do get very sick or die from COVID. And it's important to remember that while children have overall fared better than adults during the pandemic, children are not supposed to be hospitalized or die at the same rate as adults. So there cannot and should not be this one-to-one comparison with adults. COVID-19 is currently a top 10 leading cause of death for kids. There's been nearly 1,500 deaths in children and adolescents from COVID in the US alone. And we know that COVID deaths and hospitalizations have been consistently higher amongst unvaccinated children. Next slide. Thousands of children have been hospitalized. About a quarter of those required an ICU stay. And what was especially frightening is half of these were in children with no underlying conditions. Next slide. And this is despite us having solid evidence to show that COVID vaccines work. They prevent us, they reduce hospitalizations, They protect against long COVID and simply prevent things like missed school time. But we still to this day are finding that not all pediatricians and providers who see kids are strongly recommending the vaccine to their patients and families, which we will discuss more. Next slide. Not everyone realizes that Omicron really changed how worried we were about kids during the pandemic. So during the initial Omicron surge, we saw many young children hospitalized. Hospitalizations for COVID even surpassed hospitalizations for influenza. Unfortunately, we saw health inequities with Black and Hispanic Latinx individuals being more likely to be hospitalized than non-Hispanic white, which corresponded with lower vaccination rates in those populations. Next slide. We know that we need to be better about our messaging publicly and to our patients. A vaccine's primary outcome is to reduce hospitalization and death. Reducing infection is of course ideal too, but not the vaccine's main or primary goal. Similar to a seatbelt, vaccines may not stop a crash or infection, but they will significantly lower your chances of being hospitalized or dying, as well as to avoid for COVID, multi-system inflammatory syndrome and long-term symptoms. Next slide. You may or may not be surprised to know that still the biggest reason for folks not getting their bivalent COVID booster is that they were unaware that they are eligible or even aware that this new vaccine is even available and recommended. A key point I try to make is, did you get a COVID shot in September of 2022 or after that? Because if not, you're not up to date and you have not gotten the bivalent booster because it didn't come out until September. So good public messaging that's clear and not confusing has been a big struggle during the pandemic and a failure on the part of public health experts. Next slide. Here you can see just how much we are struggling with getting kids vaccinated against COVID. And it's especially hard to see this as a pediatrician because certainly we vaccinate all the time and would have hoped that we would be especially good at this. Next slide. This is national data broken down by state for 6 months to 4 years who received the initial dose of the COVID vaccine. And we're currently at 16% in Illinois. Next slide. Here's updated data for 5 to 11 years. This vaccine has been around longer than the 6 months vaccine, but still we're at only 47% with at least one dose. Next slide. Better, but not on par with older age groups is 12 to 17 years at about 71% with at least one dose. Next slide. Here is Chicago specific data showing poor coverage with the primary series, and even worse, only 2.4% of those 0 to 4 have gotten their bivalent booster to make them up to date. Next slide. There was a recent ACIP meeting in February discussing the COVID vaccines following a recent FDA meeting. They presented reassuring data showing that vaccines continue to be safe. All of our current data shows that the benefits of getting the COVID vaccine outweigh the risk for all ages. ACIP also discussed the consensus to shift to seasonal fall flu plus COVID vaccines once a year. So both CDC and FDA will continue to explore how to best annually update both vaccines to target circulating variants. There is debate about whether or not we truly are starting to see a shift to a seasonal pattern of COVID, but the thought was that this moving towards a once a year fall vaccination structure would still make sense, as vaccination in the fall would both protect folks during the winter when stress on hospital systems tends to be the greatest, as well as this would hopefully decrease confusion and then hopefully thereby increase uptake in vaccination if we align it with our fall flu campaigns. In addition, there was discussions about simplifying to using bivalent vaccines only, which could also help eliminate some confusion and make it a little bit easier on our healthcare providers using multiple different COVID vaccines at this time. So now I'll introduce Dr. Sirota to discuss the next segment of our presentation today.
Thank you, Dr. Korpex, and thank you everyone for joining us this morning. I want to tell you that here we are in 2023, and it has truly never been harder to be a pediatrician. I share that as my opinion. I think most of my colleagues would agree. We've seen illness volumes, some of which you saw in just prior slides, for the past 7 months that have been more than double what we're typically used to managing as pediatricians in primary care settings. We see anxiety rates among our patients that are at a crisis level, and we're doing the work of psychiatrists because there aren't enough to care for them. And then we've come into this very changing and challenging vaccine landscape, and in particular, where we're dealing with disinformation campaigns. And these are deliberate, often orchestrated, and highly effective in confusing our patients and their parents when it comes to vaccination. But I want to take a minute and differentiate between disinformation and misinformation, because they're not the same thing. Disinformation is deliberately providing false information that's intended to mislead individuals, whereas misinformation is inaccurate information, but it is not presented or intended with any malice. It might just be someone who innocently receives the wrong information and shares it, believing it to be true. Neither disinformation nor misinformation are considered clear scientific debate. And this is really what's become a challenge for us when we counsel and educate our patients about vaccines. You might be surprised to know that some analysis has shown us that there are essentially 12 individuals that are responsible for almost all of the disinformation campaigns in our country. And that group has been coined the disinformation dozen. They're responsible for over 65% of the misleading claims, rumors, and lies about COVID-19 vaccination that are found primarily on social media. And while the most effective platform has been Facebook for these individuals, accounting to about 73% of Facebook rumors, we know that this information bleeds very quickly into other social media platforms like Instagram and Twitter. Next slide, please. So let's look at some data around COVID vaccination and vaccination conversations in general with parents. So CS Mott's Children's Hospital in Michigan pulled a national sample of parents. It was approximately 1,500 parents, and this was done in November of 2022. And they looked at parents' recall for discussing vaccinations with parents about vaccines for their children. And in this case, only 82% of parents recalled discussing routine school vaccines. 68% recalled discussing flu vaccines with their child's pediatrician or pediatric clinician, and only 57%, so just over half, recalled having any kind of conversation around COVID vaccine. And, you know, this is concerning to us because these numbers tell us that vaccine conversations aren't happening. But I think more disturbing to me was that 1 in 7 parents reported that they didn't recall having any vaccine discussion in the past 2 years with their clinician. Next slide, please. So when we think about this and we think about recommendations, what do we need to do about this? And the way that I like to think about this is that pediatricians are a family's most trusted source of information for their child. And so the way this plays out in my practice each day is that I begin every conversation with parents when we're talking about vaccines, but especially COVID vaccines, asking them, What questions do they have for me about vaccines? Because I want to be their trusted source of information. And it's so important, as you can see just from the prior slide, that we as the pediatric clinician are providing a clear recommendation for vaccination. So you can see from additional data that was received or analyzed in this MOTS poll was that 3 in 4 parents say the recommendation of their healthcare provider will be important in their decision. And of course, where should these conversations happen? The doctor's office is the preferred vaccination location, and therefore it's important that these conversations happen there. I think we also have to note, and you heard a bit about it already, some of the health inequities that have come out of these conversations, the pandemic and illness in general, but fewer lower income as compared to higher income parents say that they're likely to have their child get a COVID vaccine. So something we also keep in mind when we're having these conversations. So when we look at vaccine recommendations, one of the things that I like to say is that saying nothing is saying something. And what that means is that if we don't bring up the conversation and we don't talk about a recommendation, it's not clear to parents that we recommend these things. Pediatricians are the most trusted source of information. Here's data to show you what I just shared. And again, we see that as recently as this Kaiser poll in November of 2021, the Kaiser Family Foundation, which has been a great resource for information about public opinion around vaccines, is that 1 in 6 parents did say that their pediatrician didn't recommend a COVID vaccine for their child. So if you look at the sort of middle bar in the royal blue and you look at the gray bar in this illustration on the right, you can see that that's a significant number of individuals who were in an office and didn't have an opportunity to have a conversation about the vaccine. Next slide. So on this slide here, what we're looking at is to say what happens with the vaccine recommendation or the lack of a vaccine conversation, and what is the impact that it has on one's willingness to vaccinate their child. And what stands out for me in this slide is that in far too many instances, there was no impact or there was no conversation, didn't even talk to the pediatrician about the vaccination. So you can see how we can be challenged with increasing our vaccination rates when these conversations are not happening. One of the things that I'm reminded of, and I just had this conversation yesterday with a nurse in my office. I was working with a nurse I don't usually work for, and we were talking about how language matters so much in the recommendation. And it had been her routine sometimes to go into a patient's room and say, "Are you interested in a COVID vaccine today?" And we talked about how asking someone if they're interested is not providing a clear recommendation for vaccination, and that we really want to move toward conversations where the nurse might say something like, "The doctor will be in shortly, and she looks forward to talking to you about COVID vaccinations today." Next slide. So if we look at implications regarding this lack of discussion, we can certainly conclude that it is a true disservice to children. The lack of a discussion with pediatricians or pediatric clinicians leave parents at a disadvantage because it doesn't allow them to make an informed decision for their children. And I can't tell you how many times, just far too many times to count, I have parents say to me, "Well, we're vaccinated. Of course we're vaccinated. I'm vaccinated. My spouse or my partner is vaccinated, but I'm still not sure I want to vaccinate for my children." So I think it's important to understand that parents do make decisions differently for themselves than they do for their children, and they need that information. Discussing, though, with a child's healthcare provider is certainly something that can move that needle. So let's look at this next slide here. And what we're looking at here is this sort of emerging trend of hesitancy around what were routine or school recommended vaccinations, extending far beyond just hesitancy or refusal of COVID-19 vaccinations. And so the Kaiser Family Foundation followed up on some Pew study work that was done to look at shifting attitudes toward other routine childhood vaccines. And what they found was that most adults, including across partisan lines, including those who have had or not had COVID-19 vaccine, felt that the benefits of childhood MMR vaccine did outweigh the risks of that particular vaccine. But when that information was compared to 2019 data, we see that more adults are now starting to say that parents should be able to decide not to vaccinate their children for routine school vaccines, and in this case, measles, mumps, and rubella. Next slide, please. So now I want to pass the baton to Stephanie Atella, who's our Chief Program Officer at the Illinois chapter of the AAP, so she can share with you some of what's been happening at the Illinois chapter of the AAP in order to promote vaccinations among children.
Thank you so much, Dr. And thank you so much for having us today. So we just wanted to pause for a moment and talk a little bit about some of the things that we've done in partnership with our local and state health departments and with our amazing pediatricians and other primary care providers who are working hard every day to advocate for vaccine uptake and good vaccine coverage in our state. So we host monthly immunization webinars that are CME accredited for our members and partners and friends. We've done a lot of just-in-time trainings every time that there is a new age group that's been eligible for COVID-19 vaccines or a new product that has come to market. And then we're also working on a project called IVAC, or Illinois Vaccinates Against COVID-19. We've been doing that for a couple of years to help support primary care providers, hospitals, and urgent care spaces in integrating COVID-19 vaccines into routine clinical workflows. So we now know these vaccines aren't going anywhere. And as our amazing clinicians on the call have mentioned, that these need to be a part of routine offerings that are made in clinical spaces to families regularly and not just cyclically or seasonally, to ensure that people are up to date with their vaccines, at least not right now, although we are perhaps moving to seasonal vaccinations instead. We've created outreach materials to help normalize COVID-19 vaccines and to combat some of the misinformation and disinformation that's available. We do advocacy here at ICAP. We've also done a few paid social media campaigns through the national AAP and grants that they gave out to each of the chapters, as well as created some clinical resources to make sense of all of the products and schedules and things that are available or out there around COVID-19 vaccines. Next slide, please. We also know, and some of the things that we've heard is that parents don't want to see their children in pain, and they have a much lower tolerance for some of the side effects that we know routine vaccinations and COVID-19 vaccines cause. It's understandable that they don't want their child to get a fever because of some of the safety measures that are in place in daycares and schools around returning back to school when a child has had a fever, and some of the testing requirements that were required and sometimes are still required when a child is displaying any illness or symptoms of illness. So we've tried to also create some tools that just comfort parents in terms of what they can do for their children before a vaccination, during the vaccination, and then after, to make their child comfortable or to help with scheduling and planning. And even we know some of our children are being vaccinated in pharmacies for the first time, and helping that those pharmacists and others who are placing vaccines in littler bodies that they might not be used to, and how some of the holds are important to that process. So this is just one of the examples of the resources that we have available, and we hope that will be used throughout the state to again help normalize vaccines and recognize some of the anxiety that goes into vaccines for people of all ages. So with that, I'll hand it back over to Dr. Sirota to talk a little bit about the amazing work that her practice has done in vaccine coverage.
So I practice in a large independent practice, as was mentioned earlier, Pediatrust. We're about 80 pediatric clinicians, mostly pediatricians and some nurse practitioners, and we practice across 20 sites, primarily around the Chicagoland area. Because we are an independent practice, we've also been able to be probably more nimble and more efficient in our approach to our COVID-19 vaccine campaign. So next slide, please. What I'm going to show you is I'm going to show you a series of slides so you can get a sense of what our vaccine coverage looks like, and then share a little bit about how we achieve that. This is my own division of Pediatrust is Pediatric Partners. So this is what I'm sharing here first. Just to clarify a couple of things, the line under 2 patients on the left that says 2 doses and a booster, probably more appropriately should say 3 doses, because we've given primarily the Pfizer vaccine, which was the first messenger RNA vaccine available for young children. And that primary series is a 3-dose series. So think of that line as saying 3 doses or completed series. And you can see for our patients in our business unit or our division, we are just over 50%. And which is great. Now, if you go down that table and you say, okay, you're practicing in Lake County, 2 doses, 1 dose, you're so much lower. Well, you have to think about the numbers. And the reason that Lake County has higher single dose and 2 dose is because some children only have 1 dose or 2 dose. But we aim for completion of this series and we're fairly successful. So the single dose and 2 dose really recommend children in our own practice who are on their way to completing their vaccination series. But if you added up all of those columns, you'd see it's quite a high number of everyone who's had at least 1 dose. Next slide, please. Our geography is quite wide across the Chicago area. And so throughout all of Pediatrust, we have practices or divisions in every collar county. And I can tell you that when we look at that individually, this is a roll-up of all of it, but when we look at it individually, vaccination rates vary considerably across the counties. And I happen to practice in Lake County where rates are higher, and in fact, in some of the zip codes where rates are particularly higher. And so that's an advantage. And I think it's important to keep that in mind, because in some of our offices, it's much more challenging to have the vaccine conversation than it is in others. But you can see if you look at completion for 6-month to 4-year-old young children across all of Pediatrust, we're at a rate of completion that far exceeds what we see in this state. Dr. Korpix showed a map of the US and Illinois at 16% currently. Next slide, please. So this is moving on to the older age groups. And in this case, the numbers are a little different because a completed series is 2 doses, and then there was an early booster. And of course, we've moved on since September of 2022, as you heard, and we have bivalent boosters available. So this gives you an idea, again, where we're quite far ahead in vaccine completion and boosting for the patients across all of Pediatrust. I will tell you, though, anecdotally, it is becoming more challenging to get bivalent boosters. So families are aware that there's a bivalent booster. They're aware of very low COVID rates in the community currently. And we're seeing that this is something that is not being prioritized. When older kids do come in for their checkup, and they are all offered and recommended that they be up to date with their COVID-19 vaccinations, what we often hear, because checkups are often during the week, is that there's concern for potential side effect, which would then keep parents or kids out of school the following day. So it's something to think about as far as planning and how we vaccinate these kids. Next slide, please. So this is just looking at our oldest age group, the 12 to 17-year-olds, and you can see similar to what we see nationally, if you look at the total number, the total percentage who've had at least a dose, and even the percent completed, it's quite a high rate and something that's approaching 75% in our practice. Next slide. So you might say, how do you do this? And we get asked that a lot. And so that's really what I want to focus on sharing. And I think the most important thing is that we do our best as clinicians providing vaccinations to create no barriers for our patients to receiving vaccines. So what that means for us is that patients were alerted in multiple formats, text messages, emails that they receive for us, notifications in the office. And we did that ahead of time. So once we saw what the cadence was from emergency use authorization, from the FDA to the ACIP, the ACIP meeting and CDC recommendations, we learned the schedule of when to alert patients, and we tried to alert them in advance so that they were prepared to make their appointments as the vaccines would be arriving. We also have the advantage of being on a fairly well-developed electronic health record, and we have a very robust patient portal, and we have a practice goal of having 100% patient portal participation. And so what that does is it allows us to have self-scheduling through our portal, and our patients were already trained to self-schedule in our portal. So our patients didn't have to worry about calling and getting through and someone answering the phones at a busy time to get vaccines. They could just go online or on their phones and schedule their own appointments. We also automatically scheduled our patients for return visits. So for example, if they were receiving a first dose of vaccine and we knew that we were doing a vaccine clinic 3 weeks later, over a couple dates, they were automatically scheduled into one of those clinics so that they didn't miss. And then of course, because this is done through patient portal, they get notifications of those upcoming appointments. Finally, we aimed to vary the sites where we offered vaccinations. And the goal, of course, was to vaccinate as many patients as possible, especially as the vaccinations were new in each of the age groups. So we referred to these as our mass vaccination clinics. We took time out of our usual work schedule to designate a couple hours a day where only COVID vaccinations were given, all hands were on deck, and everybody was providing vaccines. We have one of our offices that is very well situated and suited to drive through or drive up vaccination, which we had been doing for a few years for flu vaccines, and we were able to adopt that for COVID vaccinations. It's incredibly efficient because you don't have any of the time waste of patients moving in and out of the office. Or exam rooms for that matter. Those drive-throughs were particularly successful once we got to a point where there was a recommendation that we no longer had to observe pediatric patients for 15 minutes following vaccines. We also partnered with our community. We partnered with a very large high school that has a student population of about 4,000 students. So they had a very large space that they provided for us where we vaccinated not only thousands of our own patients on weekend clinics, but we were able also to offer vaccination to students in that school community, which serves 11 different zip codes, who did not have access through a primary care physician's office. And then finally, we had an opportunity to use some empty storefronts. So with the COVID-19 pandemic and businesses closing and vacancies, we were also able to find local landlords who opened up spaces for us that were very conducive to bringing in several patients at a time for vaccination. Next slide. So streamlining operations and efficiency is certainly another key goal for being able to have successful vaccine campaigns. For us, this meant when patients were coming that we had pre-made labels, little stickers that we put on the vaccine cards that included all the information that needed to go on the card. We always had plenty of additional cards because it's very common for patients to show up wanting their vaccine, but having forgotten their cards, or parents are busy and they forget to bring their children's cards. So we made it very easy to make new cards for patients. We often focused our clinics on just a single vaccine manufacturer. So for those of you who aren't vaccinating children for COVID-19, you may not realize that we have 13 different vaccine products that we need to keep track of at this point in time. So avoiding errors and keeping things simple certainly helps streamline our clinics. And the other thing we did is we are very diligent about medical record documentation and getting those vaccinations into that electronic health record, which links then to iCare. at the time of vaccination. And so we didn't want to lose that ability. We had seen how some of our patients that had gone elsewhere where there had been a considerable delay in reporting to eye care, and that was confusing to us if they came into the office. So we used hotspots anytime we were outside of our offices or space where we already had Wi-Fi connection, so that the EHR was used in real time for all vaccinations. And then it's also important because it takes time and it takes resources and it takes employing staff and paying them to be able to offer vaccinations in this way. So it's also very important to be mindful of how to code and get paid for providing these vaccines so that the resources are there to continue to vaccinate. And I must say the American Academy of Pediatrics and the ICAP toolkits that Ms. Satella talked about were particularly instrumental in helping physicians with this. Next slide, please. So finally, I want to talk about the importance of just overall creating a culture of vaccine confidence, or what we call a vaccinating culture. So early on, we offered several town halls for all of the staff across Pediatrust. We wanted everyone to get the same message of safety, and really to have a common base of education around the vaccines. Along with that, we required all of our employees to have COVID-19 vaccinations. And in some cases, it meant that some individuals chose to leave our practice. But we needed to be ensured that everyone that came into our office with children were getting a clear and consistent message that these vaccinations were recommended. It's really important to empower vaccine champions. Certain individuals will always stand out in a practice who really want to contribute additional efforts to see that children are vaccinated. And so we welcome those individuals and we empowered them to be part of our process. And I think it's important to note that these individuals did not have to be clinicians. In many cases, it was some of our patient reps that schedule appointments. But the most important thing is that everyone in the office, so every individual a patient meets throughout the journey through the office, our nurses, our front desk staff, our schedulers, our assistants, that they all understand our message, so that regardless of who our patients turn to, they get a clear and consistent message that includes a recommendation for the vaccine. So we celebrate vaccinations, and this helps our patients gain confidence. We do that by stickers and pins and things we wear on our clothing. I kept a nice sticker that said, I had my COVID vaccination. And then further messaging as we've gone through the pandemic, I keep it on the top of my laptop. So every time I open it and I'm in a patient room, a patient has to look at that. We have all sorts of marketing materials in our waiting room. We send out messaging regularly to make sure individuals know that they are eligible for additional vaccines if they're not up to date. And of course, we offer this vaccination and make a point of trying to have a discussion with every patient at every visit. And when it comes to patients and parents who are hesitant, we treat this as an ongoing conversation. If you try to have a conversation with someone one time and they're not interested and they leave without vaccine, you can't throw up your hands and say, never mind, I give up. Because as I said earlier, saying nothing at each of those subsequent visits is really saying something to that patient. Next slide, please. I want to finish before I pass this off to Stephanie Atella with just a couple thoughts. Learning how to have the conversation for vaccination is hard and it takes time. So I want to share one little pearl, something that works very effectively for me with hesitant parents. I approach it like I do all other motivational interviewing with parents. And what I usually say to them is I say, so where are you at right now on a scale of 1 to 10 as far as being ready to vaccinate your child? And then I let them tell me. And once they tell me where they are, and so say they say a 2 or a 3, I say, okay, well, what would it take for you to get to a 5 or a 6, or maybe even a 7? And by starting the conversation that way, it always lets me know what their questions are, what their concerns are. And then I have a focused conversation where I know they're leaving with the information that they need to hear about the vaccine that day. But this is a long game. I never thought it would be such a long game to have people accept COVID-19 vaccines. So the wins come in different forms. And I think the opportunity to even have any conversation with a family should always be considered a win.
Thank you so much. We just wanted to share a couple of additional resources and events that we have coming up. We've compiled a lot of information into a few places. So you can visit our illinoisvaccinates.com website. These are links with the slides that will work in terms of any additional resources that will help in your journey to provide vaccines and COVID-19 vaccines. We can help institutions or clinics or individuals with enrolling into eye care if you're not already engaging with COVID-19 vaccines, as that registration is required at this time to provide those vaccines in the state of Illinois. And then I think there's just one more slide with additional contact information for some of the folks who can facilitate, again, your journey to vaccinate. So thank you, Dr. Lemon and the Institute, for this opportunity to talk today about this rising public health issue regarding children and how we can address it for a positive outcome in protecting not only children and families, but the community as a whole.
Well, thank you, Stephanie. Thank you all for a really wonderful presentation. I want to remind you again to post your questions in the Q&A box or even the chat box. We have a few minutes left for questions. I want to start with, I think what was striking was the number of missed opportunities for conversations with patients in provider settings. And certainly providers are not immune to misinformation, disinformation, and they participate avidly in social media. And I wonder whether this is to what extent this has been looked into, whether there is some reluctance of many providers to really recommend this, and what has been done to kind of counter that when those sort of ambivalent perhaps feelings about vaccination, particularly to COVID, have come up.
Yeah, certainly there has been an issue on the provider side, definitely. And Stephanie did kind of allude to some of a lot of the work that ICAP has been doing, which has been amazing. Lots and lots of trainings ongoing all the time to really try to get pediatricians comfortable. We just had a nice session with Stephanie organized with your local epidemiologist, and she came and spoke to a group of pediatricians trying to emphasize the importance of the especially COVID vaccine, but certainly provider education and confidence has been a big issue.
You continue.
Okay, I was just going to say we've heard that from some of the providers throughout the state, that some of the most egregious misinformation things they've heard have been like in the lunchroom in their spaces. And so we also have created some infographics and posters just trying to illustrate and send messages about the role that everybody plays in a clinic or an organization. And I think part of why we want to make sure everyone knows about Pediatrust information and what they've done is because I think they're a wonderful example of when you do those things, you can combat some of those barriers and change the culture. And if everyone was doing what they were doing, we would probably have much better vaccination rates, because they're taking on some of that head on, I think.
And I just wanted to add that I think it's probably a very limited number of physicians who would specifically recommend against vaccine. Most physicians and most pediatricians are recommended and proponents. I think sometimes if the conversation doesn't come up, there's fatigue. There's fatigue over the issue. As I said when I started speaking, it is a hard time to be a pediatrician, and it's challenging and it's time consuming to have these conversations. And sometimes physicians are attacked personally. And so I think depending on the day and depending on who the individual is, sometimes the energy is just not there to do what it takes to have the conversation.
Difficult conversations. So here's thank you. It's a question in our Q&A is about the cost of vaccines, which are expected to rise after federal support ends, and what are what things can be done to mitigate that the cost issue that may be looming for families.
So it's a huge concern for the families, but also for children to have access, because vaccinating is a challenging aspect even to physicians who provide vaccine in independent practice. The American Academy of Pediatrics is actually advocating very heavily at the federal level for a whole host of changes so that we don't create a situation where there is an increase in health inequity as far as who's eligible to receive the vaccines. As you know, ACIP voted to make the vaccines part of the VFs, the routine vaccine schedule, so that it's available to those who are providing and receiving VFC vaccines. But it's definitely a challenge, and I think there's a lot we don't know, and I personally am grateful for the work the AAP is doing right now.
Thank you. Another question that arose, it has to do with some of the differences due to race, ethnicity, and socioeconomic status. I think that's an issue that the IOMC is particularly involved in addressing, and I just want to hear the dimensions of the issues. Dr. Korpix, you talked a little bit about this, but what have we seen in terms of the magnitude of these differences among different subgroups of families?
Yeah, it's a big issue, and one that public health has been specifically focused on because, certain populations, especially our African American and Hispanic Latinx populations in the Chicagoland area, have suffered greatly and on a larger scale from COVID-19 and the pandemic. But at the same time we've struggled with seeing even like lower vaccination rates. We know this is an access issue. Even to date, there's still an access issue, unfortunately, in a lot of our under-resourced neighborhoods and communities on the south and west sides of Chicago. We know there's less clinics that are offering the vaccine. It's a little bit more difficult to get vaccinations in those areas. So access has been the biggest issue. But we've also have made a point to address, providing education and outreach on the vaccination. There is some warranted, mistrust of the healthcare community, of the government. And so at the health department, both in the suburbs and city of Chicago, we've partnered with community-based organizations with established trust in communities to really be the ones providing that education, as well as providing pop-up clinics in community sites, at schools, et cetera. And then we also have an in-home vaccination program in the city of Chicago and in the suburbs that anyone 6 months and up, so anyone eligible for a COVID vaccine, can get vaccinated in their home free of charge.
Well, I'm afraid we've reached the end of our hour. I just want to thank again all of the speakers for a tremendous presentation, very illuminating. Again, people have access to our speakers through contact in our slides. If you have further questions. And again, our next presentation for IOMC will be at the Safe Haven Foundation on April 20th. Again, information on our website. If you're interested in becoming a fellow, contact Deborah Hodges, again, on our website. So once again, thanks for everyone for participating. Appreciate your support in this tremendous public health issue and addressing the kind of concerns that have been raised. So with that, we will close the session. Thank you.